going to start recording. So welcome everyone to our presentation on maternal cardiac arrest. I am Autumn Mells, and I'm the outreach educator for the University of Chicago Perinatal Center. My experience is I have bedside experience working at a level 3 institution. And then I have with me Dr. Ruderman. A little bit about her is that she joined the University of Chicago or North Shore MFM Fellowship in July of 2022 after finishing her residency at Northwestern. She previously completed her Master's of Public Health and undergrad studies at the University of Michigan with a special interest in health programming and advocacy, and focuses much of her research on ways to improve care delivery in the postpartum period. Throughout her fellowship, she plans to continue her public health research and hopes to participate in healthcare quality improvement projects both within the hospital and within the local community. I'll talk to you guys really quickly, just some housekeeping things. For contact hours, this activity is available for one nursing CE and then also one CME for physicians. And I will share with how to get that in the chat throughout the presentation. In order to get those, you do have to attend the entire activity. And then for nurses, you need to fill out an evaluation at the end of the presentation. Dr. Ruderman, I don't know if you want to go to the objectives really quick. So just 3 things that kind of Dr. Ruderman and I, by the end of this presentation, we want you to be able to say, like, you feel more confident in doing these things. And this includes describing the normal physiologic changes of the cardiovascular system, defining what is sudden cardiac arrest in pregnancy, and then what could be the cause of that with an emphasis on an amniotic fluid embolism. And then we will talk briefly on understanding management of SCA in pregnancy for both the mom and the fetus. And I will hand it over to Dr. Ruderman.
Great. Thank you so much. And thank you everyone for being here. As she said, I'm one of the fellows at the University of Chicago, and I'm going to be talking today about maternal cardiac arrest. I'm first going to present 2 cases. These cases are pretty close to experiences that I had in residency, and they really impacted me both emotionally, but also clinically. And so I like to use them as a way to introduce this topic and ways to think about these issues going forward. So the first case is a case on labor and delivery. You're taking care of a patient who's undergoing an induction at 37 weeks for preeclampsia. Immediately upon rupture of membranes, her blood pressure drops and you're called into the room. She endorses feeling like something is very wrong, and her blood pressure continues to drop. The heart tones become persistently category 2, and while you begin your assessment, she loses consciousness. What do you do? Next case is in the ER. So you are called to the ED for an OB emergency. The ED providers tell you that this is a 29-year-old unknown female who was brought in by ambulance after a car accident. She was coded in the fields and brought to the hospital, and during her trauma evaluation in the ED, she was found to have a fetus with a heartbeat. So you guys were called. When you arrived to the ED, they note that she has significant intra-abdominal bleeding on their FAST scan, and they just pronounced her time of death. So what do you do in that situation? I'm just going to turn off my share for 1 second and readjust. I don't think I'm in presenter mode. 1 second. Sorry about that. Oh my gosh. There we go. That's better. Okay.
I think you might have to stop and reshare, Dr. Ruderman.
Oh, okay. Is that better? Can you all see now?
Yeah, you're on case 2.
Okay, great. All right. Sorry about that. So I'm going to talk briefly about the normal physiologic pregnancy adaptations, because I think that in order to understand how to manage adverse cardiac events in pregnancy and postpartum, it's helpful to refresh ourselves on pregnancy physiology. So pregnancy causes a variety of changes, as you know, to accommodate maternal and fetal circulatory requirements. And most pregnant people can tolerate these changes. So really briefly, in terms of heart changes, the cardiac output will rise 30 to 50% and heart rate will increase 15 to 20 beats per minute. The enlarging uterus will cause an increase in the afterload through compression of the aorta and decreased cardiac return through compression of the IVC. So that's why often when we lay our patients supine, you'll note that they're hypotensive. Blood volume will increase approximately 30 to 50%, and this actually happens as early as 6 weeks gestation. You'll also note a physiologic anemia from the increase in blood volume. Systemic vascular resistance decreases to accommodate uteroplacental blood flow without overloading the maternal circulatory system, and also decreases through the release of endogenous vasodilators like progesterone. Ventilation in pregnancy increases. There's a physiologic mild respiratory alkalosis of pregnancy, and that favors fetal blood exchange. And our functional residual capacity decreases 10 to 25% as the uterus enlarges and elevates the diaphragm. So you can see in the diagram in the bottom right corner, the outline of the lungs and heart in the pregnant and non-pregnant state. And finally, clotting factors increase, as you know, as a protective effect for the actual delivery, but that also increases our risk of thromboembolism during pregnancy. So this chart, which is from ACOG, which I think is really helpful, is looking at the changes, the physiologic changes, antepartum, intrapartum, and postpartum. You can see that antepartum, you're going to have increases in cardiac output and heart rate, and then ultimately an increase in blood pressure. And this is mostly due to hormonal changes, so increases in estrogen, progesterone, and in the renin-angiotensin aldosterone system. And the compression of the IVC, as I mentioned, will reduce venous return to the right ventricle. Intrapartum, you can see there's really dramatic changes in cardiac output, heart rate, blood pressure, and plasma volume that vary throughout labor, but also between and during contractions. And then postpartum, you can see that the cardiac output immediately after delivery rapidly increases, but then falls off. And you'll note that at days 3 to 6 postpartum, blood pressure will increase again, which is often why we see a lot of patients return to the emergency room around then. And finally, I think a lot of us were taught that at 6 weeks postpartum, pregnancy physiology is resolved, but I think we all know that it takes a little bit longer, especially when our patients are breastfeeding. So I'm going to pass it back to Autumn to talk about maternal morbidity and mortality in Illinois.
So I'm guessing a lot of you on here have read the maternal mortality report that came out from IDPH in 2021, but Dr. Ruderman and I just kind of wanted to point out some important points, especially when we're talking about maternal cardiac arrest. And the first thing that, or not the first thing, but one of the things they talk about in the report is what redlining, which already started in the 1930s, has kind of done to our population and also has having an impact on our pregnant patients. So I promise we'll bring it full circle, but in 1930s, right, what the redlining essentially did was it rated neighborhoods and made some neighborhoods more favorable to live than others. And what that has done, and we still see the effects of that today, is some places, right, are lacking like grocery stores or access to fresh produce, access to healthcare facilities, clinics. And we see this in discrepancies in even lifespans of neighborhoods. So an example that they gave in the maternal mortality report is when we think of Inglewood. Inglewood is predominantly majority low income Black neighborhood, and they have an average lifespan of 60 years old. Versus if we look at Streeterville, Streeterville is majority upper income white, and the average lifespan there is 90 years old. So we're seeing a big differences with outcomes on people's lives versus where they live. And what does this do to our perinatal population? Well, really what it does is it gives, unfortunately, these patients have a lack of high quality education, which we know that can have a detrimental impact on our patients, a lack of access to food, lack of grocery stores, and also trauma deserts and issues accessing care. It's not necessarily as easy for someone maybe in a low income area to get to the physician's office or get to the hospital, right? It could take them a half day or something to get there. They don't just jump in their car. So we do see the impacts of this still today on our maternal patients. Another factor within the maternal mortality report is the differences between a pregnancy-associated death and a pregnancy-related death. Now, a little bit about, if you don't know too much about how these cases are reviewed within the state of Illinois, we review them at our hospital levels. If there is a severe maternal mortality morbidity, we look at that. But then it also gets brought to the state level where there's a MMRC and then MMRV, where they look at the case and try and determine, was it pregnancy related or pregnancy associated? Now, the difference is that pregnancy associated is the death of a woman during pregnancy or within 1 year of the pregnancy from any cause. Where when we see that pregnancy related, it's something specific from that pregnancy that caused, right? Like a domino effect of why that patient ended up expiring. So it is deriving specifically from that pregnancy. So we see a little bit of a difference within the pregnancy versus pregnancy associated. So when we look at in the state, this is just for the state of Illinois, right? So this is just from our maternal mortality report. When you look at the number of pregnancy associated deaths in Illinois, and kind of what happens is that we do see this steady increase. Unfortunately, we do see a couple little dips in a few of the years. But our last one in 2017, the data does come out a little bit later. We do see it go up a little bit. And there could be some variety of different thoughts on why that's happening, but it is interesting because this is just the state of Illinois, but actually the CDC talks about that there is a steady rise in both maternal mortality rates and also near miss rates at the national level, which almost correlates to what we're seeing here in Illinois. And then the last thing from the maternal mortality report that we just want to talk about is just the timing of when these pregnancy associated deaths are happening. And I think it's interesting looking at this graph and how they point out that 30% of the women that died in 2016, 2017, right, is that it happened when they were pregnant. And then the other, another big chunk of it, if we look, is at that 33%, which was 6 to 11 months. So that accounts for 63% of these patients expiring were during that pregnancy or that 6 to 11 month period. So I think that brings out an important point that Dr. Rudeman had already said, that it takes longer, right? We just sometimes think that 6 to 8 week period and then that patient's better, when really, right, it could be a longer time span. So I want to talk about why are maternal mortality outcomes suffering? Why are we here talking about maternal cardiac arrest? Well, when preparing for this discussion, some of the things that I had found in some of the literature talked about that there's a lot of concern about lack of knowledge deficits and a lack of standardization in the hospitals. And this comes from both a nursing and I think a physician perspective. From what I was finding is that not necessarily a lot of nurses, nor maybe even OB physicians, right, necessarily feel comfortable with handling, right, like maybe a maternal cardiac arrest. It's something that we don't necessarily do a lot. So we don't maybe necessarily feel the most prepared or the most comfortable doing it, which makes sense, right, because it's not something we have done often or want to do often. The other thing that we're seeing on why our maternal mortality rates increasing is that there's increasing burden of chronic disease. We're seeing more and more patients who are having some type of underlying condition. We're seeing more patients who are now older having children, and then we are seeing an increase in the body habitus as well of our patients. And then something that we've kind of, it is in the maternal mortality report, but that I kind of talked about with the redlining too, is that we are seeing dissimilar care when we think about care for minorities. So we do know that some specific patient populations, we're not seeing the same outcomes that we're seeing for others. And that's something that we still, as a whole, both nurses and physicians need to continue to work on the care for our patients. So when I think about all of these things, right, we're all like, oh no, we might be like kicking ourselves, right? We have so much work to do, areas that we can improve, which we can always improve. But I do think the thing to look about related to maternal cardiac arrest on here in bold is that if a patient survives the cardiac arrest, if we can increase our resuscitation efforts, increase our ability to take care of these patients, is that hospital discharge rate can be as high as 58.9%, which when we think about the non-pregnant population, their discharge rate isn't as high. So we do know that pregnant women who do suffer, or postpartum women who suffer these maternal cardiac arrest do have a better outcome maybe than the non. So what are we going to do, hopefully, to combat these M&M rates? We said that they're slowly increasing, unfortunately, but educating women and healthcare professionals about recognizing the early maternal warning signs and when they need to be reported and when further assessment is required. I know ACOG has a whole initiative on the Safe Motherhood Initiative with a safety bundle that focuses around the early maternal warning signs. I encourage your facility, if you guys don't have anything in place on the early maternal warning signs, to look into that. I will include that in the chat. but it's kind of a great way to recognize when a patient condition is maybe deteriorating. Maybe it's looking more slow deterioration. It kind of alerts us when vital signs are off, lab results are off, and maybe that would then kind of push the nurse per se to then call the physician, who would then come to the bedside and do an exam. So I think as healthcare providers, we need to be ready, patients need to be ready, and we need to just know those early warning signs to best care for our patients.
Great. So on that note, I'm going to jump into kind of the background on causes of maternal cardiac arrest that you can kind of have in your back pocket when you see that a patient isn't doing well, as well as a specific focus on amniotic fluid embolism, because I know that's a really rare but really deadly condition that not everyone has seen. So in terms of the causes of maternal cardiac arrest, ACOG lays it out nicely, and also the American Heart Association, of the ABCs of maternal cardiac arrest. So I find it to be a little bit easier to remember when you think through it in this way. A's being anesthetic complications such as a high spinal, B being bleeding, C cardiovascular disorders like MIs, D for drugs, most notably MAG, E for embolism, including both pulmonary embolism and AFE, F fever, so think choreo, G, the general H's and T's, which I'll get to shortly, and then H, hypertensive disorders, including stroke, which is pretty relevant in our high-risk population. Notably, the ABCDEs don't reflect the prevalence and commonality of the condition. So obviously the most common condition predisposing a maternal cardiac arrest is going to be a hemorrhage, and then following that an AFE, acute coronary syndrome, and pulmonary embolism. So I know when we were all in training, we learned about the H's and T's that cause cardiac arrest in a general population. So always important to think about this, especially if the patient is presented from the outside to the emergency room. So hypovolemia, obviously with hemorrhage, can be seen. Hypoxia, pregnant women do become hypoxic quicker, and we'll talk about airway management a little bit later. Acidosis is definitely something that I've seen before. Electrolyte derangements, hypothermia, hypoglycemia. Those last two, not as common to see on your labor floor, but certainly can be seen in the emergency room, for example, for a type 1 diabetic that comes in and is pregnant. The T's include toxins, so drugs that we give the patients or drugs that the patient takes. Tamponade and tension pneumothorax in our population are usually the result of some sort of trauma. And then, of course, thrombosis, including MI and PE. So SMFM has a really nice practice document that is widely available and freely available on the internet. So this graph is taken right from their practice document on amniotic fluid embolism. And so the pathophysiology of AFE is honestly very complex and not totally understood. But the general idea is that
Oh gosh, you scared me.
Oh, do you mind just muting? Thank you. So an AFE is thought to be the result of a complex series of events. And the thought process is that it's more like an anaphylactic reaction that some patients have and some patients don't. When you actually look in the autopsy of moms that passed away from other reasons, there actually are amniotic and fetal fluid particles, for example, in the lungs of people that did not have an AFE. So that's not really a way that we can make this diagnosis. The thought is that the amniotic fluid gets into the maternal circulation and really overactivates the immune system. This releases vasoactive and procoagulant factors, so that does a few things. It causes pulmonary pressure to increase, and ultimately the right ventricle fails. And once the right ventricle fails, the left ventricle will fail, and then the patient will become very hypotensive. You'll also get direct hypoxic injury to the lungs and the heart, and you'll see acute respiratory failure with severe hypoxemia. And finally, as I mentioned, the release of those procoagulant factors really causes a coagulopathy. And so when I think about this, I think about three kind of main steps. you'll see often a change in mental status. So anxiety, as our case said, that patient said, I really feel like something is wrong. And I've had that before where I had a patient just say, I feel like something really bad's about to happen to me. Then followed by cardiovascular collapse, with progression to cardiac arrest. And obviously, if your mom is not perfusing, the fetus will not be perfused. So you'll see often a terminal fetal bradycardia, and then DIC. So unlike just uterine hemorrhage, where you get the hemorrhage and then you get DIC, in AFE, the DIC comes first. So you'll often see it reflected in the labs. You'll see bleeding from IVs, bleeding from the vagina, bleeding from the urethra. That's pretty profound. And then the other two main points that I'd like to make is that usually these occur during labor or within 30 minutes of placental delivery. And there should be no fever during labor as well to classically make this clinical diagnosis. So in the management of an AFE specifically, it's really critical to start high quality CPR and ACLS right away. Mobilize your team. So if you have MFMs, that's great, but you don't necessarily need them. The right people are in the hospital. It's just a matter of getting them where they need to be. So that might be critical care providers, emergency room providers. Definitely want your obstetrician and your anesthesiologist. And if the patient is still pregnant, your pediatrician or NICU providers. As I mentioned, a big portion of this pathophysiology stems from the right ventricle failing. So in that sense, you want to perfuse them, but you want to avoid excess fluid resuscitation. And then, of course, we'll talk about perimortem or resuscitative cesarean section. And so think about that really as soon as it starts. With AFE, you are going to want to activate your massive transfusion protocol right away. So you want that to be active right away. And if patients don't survive, they usually don't from cardiac arrest. So just being well aware of the steps of maternal CPR and maternal ACLS. This checklist is available from SMFM online, and we will link it. So basically, they have this developed this checklist for providers to use in place at their hospitals. And as you can see, there's four main categories. The first is managing the circulatory collapse. The second is managing the hemorrhage. The third is managing the airway and cardiovascular system, and then a post-event debrief. And SMFM really recommends, if you plan on implementing this at your hospital, to have a multidisciplinary group review it first, take out what doesn't work for you or what's not available, put in things that you think are missing, and then publicize it widely, run it in simulations so that it can actually work for you. So what can you do in this situation? I say practice, because that's really the best thing we can do to prepare ourselves for maternal cardiac arrest. Having been in those situations, I think, being prepared doesn't mean you won't be scared in the moment. It's impossible to not be afraid. Our patients are afraid, their families are afraid, but the more you think about these things and kind of mentally rehearse them, the easier it is. So that means preparing for a cardiac arrest, a perimortem cesarean, obstetric complications that necessarily follow, and neonatal resuscitation. And what I mean by obstetric complications is, take AFE, for example. We know that even if we stabilize the patient, the DIC is already in process. So think about the hemorrhage that's coming, get your uterotonics in the room, things like that. So in terms of just basic life support and ACLS, a brief overview. So whenever you think about maternal cardiac arrest, you always want to think about compressions first. You want to just get to the chest as soon as possible while you're mobilizing your team. Airway is something else to think about. You need an airway, obviously, and pregnant women classically have more difficult airways that may require smaller ET tubes. And so calling in your anesthesia colleagues is really important, but also just bag masking, watching for the chest rise and fall. And then that goes to breathing, just making sure that they're actually getting what you're giving them. Compressions, so notably chest compressions should be similar to people that aren't pregnant. So the goal is about 100 to 120 compressions per minute, and you do a compression ventilation ratio of 30:2. So considerations for pregnant patients, we don't want their bed tilted overall. We ideally like a hard backboard under their bed. And the nice thing about newer hospital beds is there's usually a CPR button that you can just press and it does that for you. You want to manually displace the uterus to the left, which is going to take that pressure off the IBC. And then don't hesitate to put the AED pads right away. And as we'll mention, most AED machines have automatic settings where they'll tell you if the rhythm is shockable. Pregnant women can be defibrillated with the same amount of joules as a non-pregnant patient. And notably, we recommend, of course, during this whole thing, remove fetal monitors, so external monitors and internal, but don't delay giving someone a shock if you're having trouble getting those internal monitors off. So in terms of a deeper dive on airway and breathing, oxygenation, they recommend oxygenating with 100% oxygen by face mask, so 8 to 10 breaths per minute before you intubate them. And if you don't see the chest rise, just readjust. We know that moms have an increased risk of aspiration due to increased intra-abdominal pressure. And so that's just something to keep in mind when you're managing a pregnant person's airway. And you're probably thinking, should I be worried about the baby? Should I be monitoring? All of the big organizations, so the American Heart Association, ACOG, SMFM, recommend not doing fetal monitoring during resuscitation. Again, get those monitors off as fast as you can, and let maternal status guide resuscitation, not fetal. So the classic 4-5 rule is that in maternal resuscitation, at 4 minutes, you're going to want to do your perimortem or resuscitative C-section if the patient is greater than 20 weeks gestation. And at 5 minutes, you want to deliver the baby, even if it's a demise, because you're still trying to resuscitate the mom, which is why a lot of people have moved away from calling it a perimortem to calling it a resuscitative section. In real life, I can tell you that the 4 minute, 5 minute goal is really just that. It's just a goal. And so you can try to aim for 4 to 5 minutes, but really you just try to do everything kind of at once. And we'll talk about that, and just try to do everything as fast as possible. The other thing to note is that classically, I know our emergency physician colleagues will learn to do perimortem sections with a midline vertical incision. And for the providers on this call, I think just really important to know that it is okay, and ACOG and SMFM acknowledge that a fan and steel incision may be easier and faster for us. So I just wanted to put this up. This is the BLS algorithm for pregnancy, which we basically just went over, but just briefly, first step being check the pulse. If no pulse, get on the chest, start doing compressions, apply the AED, and activate your emergency response team. The two boxes at the bottom are pretty helpful reminders of the things we spoke about chest compressions in pregnancy, as well as appropriate airway management for pregnancy. Similarly, this is the ACLS cardiac arrest algorithm, which goes over the etiologies of the arrest, which we discussed, the OB interventions, and the maternal interventions. And I just think these are really helpful graphs that honestly I just screenshot on my phone, keep in my phone, and from time to time just remind myself the right steps for management. So post-arrest care, usually after a cardiac arrest, if the patient was pregnant, they will not be pregnant anymore. But if they are still pregnant, make sure they're in a lateral position and that you're monitoring the fetus once the mom is stabilized. You're, of course, going to want to transfer to an ICU or to a higher level of care for monitoring and stabilization. And you're going to want to continue to include your multidisciplinary care team. Something that I'll note is that if, for example, you're doing a perimortem cesarean section and you are doing it in the LDR, you should not be moving to the OR to do that. You should stay right where you are, whether that's the LDR, the ER, stay there, and then you can decide later, do you want to go to the OR for more procedures? So, in getting back to our cases, so the first case was really an intrapartum loss of consciousness. And you could think about your differential being an MI, a PE, a high spinal. But I included that sentence of like, I really feel like something is wrong because AFEs really do classically come with this sense of impending doom, and they are quite dramatic. The graphic on the right kind of demonstrates that these situations are really tough because you're needing to think about what's going on, respond, and plan ahead and manage it all at the same time. And unfortunately, there's just not enough time to sequentially go through those steps. So at the same time, you're responding, you're activating your team, calling an assessment, checking for a pulse, starting CPR, and calling a code. And depending on your hospital system, you may have to call multiple codes. I know where I trained, if we had a maternal arrest, we had to call 3 codes. We had to call a maternal code, a neonatal code, and we had to call a code to get the ECMO team there, which I'll talk about in a second. So consider your differential, as I said. Was the patient on magnesium? Give calcium gluconate. Is the patient hemorrhaging and you didn't realize it? Check the vitals, put them on continuous O2 sat. Think about what could be going on while you're mobilizing your team. And then planning ahead. So you know that if they are having this event, there are really high likelihood that when they recover, they're going to have a coagulopathy. You're going to assemble your cesarean instruments. So think about what that means in your hospital. Does that mean that you have a emergency C-section tray with you? Does that mean that when you go to the ER, you know where all the instruments are? Call your ICU, call your other providers that are around the hospital that might be able to help you. And then depending on where you practice, you may have access to an ECMO team, so extracorporeal membrane oxygenation team, which in a lot of these cases is really helpful. I will note that in cases such as AFE, SMFM actually doesn't recommend using ECMO because patients need to be anticoagulated to be on ECMO, and because of the DIC and AFE, that's really just not possible. And this second case is a little bit different. So thinking about maternal trauma at an unknown gestational age. So again, we're thinking about our immediate response, our differential, and we're planning ahead. So in this situation, you go to the emergency room and you have a patient who has been pronounced dead. What do? First, you want to verify for yourself. You want to verify her status. Make sure that you check a pulse, make sure that you confirm with your ER providers that they have pronounced her. Then check for yourself the fetal status. They say there's a baby with a heartbeat, put the ultrasound on her belly and make sure you check for yourself. And a really important part of that is estimating gestational age. So if the umbilicus is, or if the uterus is at the umbilicus, you can guess that the fetus is about 20 weeks gestation. Obviously, this gets harder with certain different habitus, or in this case, when there was a lot of blood in the belly, but that's the best you can do. And in the moment, you just have to go with what you can do. You want to activate your team, especially if you're in the emergency room and the patient is still alive, activating your trauma team. And considering your differential. So this patient was brought in by ambulance and you know there's been a trauma, there's been a car accident. So you're guessing massive blood loss has been the preceding event. But was the patient actually impacted in the car accident, or did she just lose consciousness? Did she have a pulmonary embolism? Things like that. So don't always assume that someone that's brought in by ambulance has had a trauma. And then plan ahead. So again, you want to think about your perimortem C-section. And in this case, obviously, the mother is deceased. So you're going to proceed with delivery immediately and not wait those 5 minutes. And I think Autumn's going to speak to this in a little bit, but I think all of us need to acknowledge that these situations are tough and that we need support as much as our patients and their families need support. And I think working together is really important. Some of the research that I read found that there is actual predictive value of bedside nurses feeling uncomfortable. And so we just really need to listen to each other and work as a team in order to manage these situations. So I'll pass it back off to Autumn.
Yeah, thanks, Dr. Ruderman. I think, when Dr. Ruderman and I met to talk about this, we both said like our experiences with a patient who arrested and just kind of like that secondary trauma from what we witnessed happen. And when you're in the moment, you don't really think about it and it might not hit you till a little bit later. So I think her and I just both wanted to say, like, just making sure that, after these situations that you take care of yourself and in a healthy way, and just think about talking to the other team members, debriefing that as a group. And I think, nursing, physician, the co-team, whoever was involved, everyone just kind of walking through what went well, areas for improvement, but then also just being real about your feelings because we're people too. And seeing these things happen, no one signs up, right, to watch a maternal cardiac arrest, and it can be a difficult situation. So just making sure that you take care of yourself. I know some institutions have like they'll do the debriefs where, chaplains come. The M&M too, I think, is always really helpful to attend as well. But then also employee assistance programs, anything extra that your facility has, I encourage you to utilize that. So just taking care of yourself, I think, after these situations is important. And then the other thing, when you're thinking about, and I know this might be causing anxiety, people hearing this about taking care of yourself, like, I don't ever want to see this happen. None of us do, whether you're a physician or a nurse, none of us want to see this happen. But we also have to make sure that we're prepared so that if it does, that we're ready. So part of that is like a mental rehearsal. And whenever I'm teaching nurses about this, I oftentimes talk to them about like, what are the first 10 things that you're going to do? You're in your patient's room, she becomes unconscious. Like, if you had to pick just 10 top things, what is that going to entail? So even just walking through that, like next time you're at work or, just what would I do? Do I know how to call a code? I know that's something we don't do a lot in labor and delivery. So would you know the process for that? If you call maternal code blue, then do you call NEO, just like Dr. Ruderman was saying? How do you call your code? Where is your code card? Do you know how to use an AED? Making sure you know the algorithm for ACLS. Dr. Ruderman had showed that, but a lot of the care that a pregnant woman should get, right? ACLS is all the same. A woman should be shocked. She should be given all the same medications of a person who's in arrest who isn't pregnant. So do you feel comfortable giving compressions or ventilations? Do you know where your emergency, like if you had to do a resuscitative section, do you know where that emergency cart is? And then I don't know, Dr. Ruderman, maybe you already said this, but the other thing too is like knowing that like you don't move, right? You do your cesarean section wherever you are, right? Like in the triage room, at the patient's bedside, in the ED. It's just kind of mobilizing all of those things. So I think just practicing it, and Dr. Ruderman said this, practice, because it's not something we do often. So getting that used to the compressions and the ventilations and who do I call? I know as an educator, I've done drills at a couple of our facilities on maternal cardiac arrest, and it's been really helpful, I think, for the staff just to walk through like, who do we call? What do we do? Because it isn't something that we necessarily do all the time.
And I would just mention that, for people that may work at multiple hospitals, or if there's any trainees on the call, I know that when I was a trainee, the first month of labor and delivery, we would do a tour of the floor and pick out where is the code cart, where is the AED, who do we call, where is the backboard, just so that everyone is kind of mentally thinking about this and refreshing on a regular basis.
Mm-hmm. I think the other thing, I worked at level 3 facility, but I sometimes go to level 0s or level 1s. That's important too, to think like, just because you're not a level 3 doesn't mean this isn't going to happen too. So I think the different levels of care too, just making sure you're prepared as well. So these are some of our key points, reviewing this presentation that we just wanted you guys to make sure that you take away, making sure that you know how to call that maternal code. If you have a specific maternal code, there is some evidence showing that calling a maternal code is a lot better than just calling a regular code blue to labor and delivery. It paints a different picture, right? What your code team and who's expected to be there. Making sure that we know how to do high quality CPR with the patient flat on her back, which then leads me into that lateral uterine displacement. So making sure that you have enough people to also do that uterine displacement, which can be kind of tricky at first if someone's not used to it. And then not delaying your CPR or defibrillation or any other resuscitative measures. I specifically remember a physician once who I was with, we were bringing a patient up to a more critical unit. And I remember the accepting physician was like, what meds can we give? And they were like, you can give her anything to keep her alive, right? So we shouldn't be withholding any medications or any treatment. We already talked about that 4-5 rule is our goal. It is amazing how fast 4-5 minutes goes by when you're in a situation like this, even though it feels like forever. So if you do drills or practice, I encourage you guys to just time yourself and see that time frame. Early delivery is key to maternal resuscitation. So remember that delivery also does aid in ROSC of mom. And then, so maternal status should guide resuscitation. Then that leads me into that. Any IV fluids, antibiotics, anything that is infusing into the patient should all be turned off, just because there could be a correlation with potentially the MAG or maybe the epidural dosage, right? That could be leading to the arrest. So anything should be turned off. And then, as I already kind of said, just the dealing with that secondary trauma and making sure that you are taking care of yourself and being transparent with your colleagues around you, I think is really important. Dr. Ruderman, did you have anything else to add to this?
Yeah, I would just say that I think something that we've probably all experienced, as Autumn said, is when you have a provider who's not used to taking care of pregnant patients. And I find that a lot of times they really get hooked on what's safe for the baby. I had a patient who was in the ICU recently, and she was intubated and sedated, and the ICU providers just kept worrying about the baby. And ultimately, I just said, the baby's not going to survive if the mom doesn't survive. So let's treat the mom. And I think that really hit home with them. So sometimes you just do need to be explicit that there is no baby if there is no mom. So, and then I just wanted to share some resources that I find really helpful. The Critical Care Obstetrics podcast and Creags Over Coffee. So the Critical Care Obstetrics podcast is about these kind of situations, and often is about like cross collaboration between multiple levels of providers. So I think it's a really nice refresher. And then Creags Over Coffee is actually a podcast for OB-GYN residents, but I think that they have a lot of really helpful information on management. A lot of it is based off of ACOG practice guidelines. That's just nice if you ever are looking for more information about a certain condition that you're seeing on labor and delivery. As I mentioned, the Society for Maternal Fetal Medicine, or SMFM, has a lot of free guidelines and checklists that are available on their website. You don't need to be a member to access them. And then just one thing I would also recommend you check out is the Hear Her CDC campaign, which is just about listening to our patients and listening to our colleagues, and actually going to assess and evaluate our patients when they say that something's wrong, because our patients and our colleagues, especially our bedside nurses, really know and can sense when something is up. And if they feel uncomfortable, we should do our job and go assess the patient. Autumn, do you have anything else to add to that?
No, you covered it.
Okay. So these are our references, and we're happy to take any questions or talk offline about our experiences if that would be helpful for anyone.
Dr. Ruderman, do you mind going to the next slide? So these are our references, but just for CEs or CMEs, if you guys, nurses, you can scan this QR code, and physicians, you can text that code, and then we'll just keep this slide on. But we did want to, I do know some have questions in the chat. Or if you guys want to unmute, feel free to unmute. But someone did ask, Dr. Ruderman, do all ED providers, are they able or capable of doing a C-section?
I mean, I am not an ED provider, so I can't say that I know if they're able to, but at the end of the day, as someone that does C-sections in an emergency, it's not that tricky. You really make 2 incisions, one on the skin through the fascia and one on the uterus, and deliver the baby. I know that sounds really hard if you've never delivered a baby before, but I do think that they could figure it out, and it should be part of their training, at least in simulations. And they are classically taught to do a midline vertical incision because that makes the trauma eval easier. When I have done a perimortem section, we have only ever done it via fan and steel incision.
Thank you. The next question is, if you successfully resuscitate the mom, do you necessarily have to deliver the baby, especially when the baby is extremely preterm?
Definitely not. I would say that if you, for example, if you have a transient AFE, which I've definitely seen before, I mean, this wouldn't really apply because it would usually be in labor and delivery. But if you have a transient loss of consciousness and a code that you obtain ROSC within a minute or two, you definitely don't need to deliver, especially if the fetus is really premature. And as we said, there's just things to note. So things like tilting the mom when you go to the ICU, as soon as the mom is stabilized, you should be monitoring the baby. Of course, we don't really care about fetal monitoring if mom is super unstable, which is what we often do here when we have critically ill patients in the ICU. But when they are stable in the ICU, definitely want to monitor baby or talk with the family about their wishes for monitoring. And then once you're over that initial cardiac arrest, then you can start thinking about the fetal status and what are the indications for delivery. Unfortunately, a lot of times in these situations with AFE or with an MI or a PE, they're really unexpected, right? So you can't prepare for them and you can't have discussions with the family. But if you do have a patient that's critically ill, let's say, we saw this a lot with COVID, and having those important conversations with the families about how much fetal monitoring you want, when do you want us to intervene, is really, really important.
Thank you. The next question is, would you say that all facilities should be required to have a bedside C-section cart?
I can't speak to all facilities. I just don't know enough about healthcare delivery services, but I definitely think on labor and delivery, you should. I mean, all you need is a scalpel at the end of the day. So that those should be available in every labor room. And in the emergency room, having been in that situation in the emergency room, honestly, after I was in a perimortem in the emergency room, whenever I went to the ER and there was a critical patient or I was called to an OB emergency, I brought a disposable scalpel with me because I didn't want to have to put the scalpel together again, which was something that like we had struggled with in the moment. So I think thinking about those things with your ED providers, that being handed a huge tray of instruments and having to find the scalpel in the moment is just not going to work. And so working with your ED providers and of course, if you have a patient already in the ICU, having not only a C-section tray at bedside, but also like a neonatal stork tower for neonatal resuscitation, and working closely with your NICU colleagues for that.
Great, thanks. There's a question in the chat. Due to possible regurgitation, should a garage tube passed? Question mark. I don't know if you see that question, Dr. Ruderman.
Maybe you're asking about an NG tube, a nasogastric tube.
So I'm guessing.
I think it depends on the clinical situation. I think, if it's someone who's been in labor and been on a clear diet, I don't think that's really necessary. I think if they come in from the outside or, that they have a lot of contents in their stomach, it's definitely something to consider. But I think that's kind of like not top of mind or top priority during a maternal arrest.
Thanks. Does anyone else have any questions? You can unmute too if you want.
Yeah, feel free to share your video. All right.
Not, this is the information, hopefully physicians, you're able to get your CMEs appropriately, and nurses. I put the link in the chat and also the QR code here. I know there's questions about the recording. I will try and finish the recording in the next couple of weeks and have that up on our website is the plan where that should go. Otherwise, if you guys have any specific questions, you can reach out to me. My email is down here. And that is all we have for you for today. Thanks for coming.
Thank you.